Hi, Dr. Rozell. Welcome to MD Newsline. For people who don't know you, can you please introduce yourself to our audience?
Hi, I'm Dr. Shaina Rozell. I'm a hematologist oncologist with Affiliated Oncology here in Chicago, Illinois.
So, there's a lot going on in the world of multiple myeloma these days, and there have been a lot of new development. I'm so curious, what new developments have caught your eye?
Yeah, it's been a insane and fun time in the world of multiple myeloma. Even being in a private practice, a lot of the questions is how do you actually keep up? And for some time, we learned all about triplet therapy, and so it was at the time the standard of care to use, for instance, Velcade, Revlimid, dexamethasone, and that was your standard of care. However, more recently, for the last several years, we have been learning more about the quadruplet therapies, and so I think it's been extremely exciting to look at daratumumab, and now isatuximab, and using these novel quadruplet therapies in treating our patients. We have had a wonderful sustained MRD with the use of these quadruplet therapies, and so I think it's exciting to see that these patients are doing well, they're living longer, and many of them have been able to avoid stem cell transplants.
Yeah. Can you explain MRD and how it plays a role in treatment?
Yeah, so MRD, or minimal residual disease, is pretty much a surrogate of seeing how well the bone marrow is without any evidence of disease. It has allowed us to see, it's been a surrogate for progression-free survival. It is a surrogate of a sustained response to the therapies. It has been a way to guide our treatments, and so I think it's the new marker. In terms of, for instance, progression-free survival, overall survival.
So, when you're thinking about things like cell transplants, right? When do you consider autologous cell transplant in the era of advanced immunotherapies?
So that's a very loaded question. I think for years and years, the mainstay of treatment was the stem cell transplant. And so, you would give your patients treatment, and then the ultimate goal is that they would go to stem cell transplant. And so, what we learned is that many patients are not able to have stem cell transplant just based off of, age, other performance status. And so with those patients, they're not able to receive stem cell transplants. And so they did not have a great advantage as those that who actually could receive stem cell transplant. But that has changed with the advent of the quadruplet therapies as well as the bispecifics and CAR T. We've seen that patients have done extremely well, and again still had a sustained minimal residual disease, and similar to someone who actually had a stem cell transplant. And so I don't think it has been replaced, but I think it's still a adjunct. Um, and I think over time, we may not be performing stem cell transplants. I can think about the days we did stem cell transplants for breast cancer, and that's pretty much obsolete and not existent. We don't do that anymore. And so the hope is that, we may be able to stop doing or performing stem cell transplants in the future. Maybe, maybe not.